Okay, let's start. Hello, everyone. Good afternoon. I'm Ziad Malat from the Division of Cardiovascular Medicine. Welcome to this session of the Grand Round. The first talk will be from Renal Medicine by Mark McClure on behalf of Sanjay Oja, a blunt razor. Mark, please go ahead.
Hello, good afternoon, everyone. So hi, I'm Mark McClure, I'm at Renal Reg, and thanks very much for the opportunity to present this case. So this was jointly managed by renal hematology and respiratory teams just before Christmas. And it had us all scratching our heads somewhat. So we thought it would make excellent fodder for Adam Brooks' Grand Round. So here goes. This was a 31-year-old man who was fit and well, no past medical history. He worked for Argos, delivering whole, but not to excess. His dad had type 1 diabetes, but there were no other medical conditions running in the family. So symptom onset was the 14th of November, and this was with diarrhea. But it was pretty mild diarrhea, really. He reported it was slightly loose over 2 days, and then that settled. And then 1 week later, had a night of very, very loose diarrhea. It just stopped with a bit of low perimide, but it was no blood. It was non-bloody diarrhea. There was intermittent, crampy abdominal discomfort. There was some constitutional upset with a bit of malaise and fatigue. No other symptoms to report, but he was unwell enough to present
Hi, Mark. You seem to have frozen there. Is your internet still playing up?
Good urine output. He was treated then with IV fluids. He had some blood cultures taken, empirical antibiotics, and he was given IV bisphosphonate for the calcium. However, despite aggressive filling with IV fluids, the following day his renal function deteriorated and his creatinine now rose to 330. He became anemic, his HB dropped to 104, and there was a marked thrombocytopenia, with platelets acutely dropping from about 350 to 30. So where
Mark, can you hear us? There is a problem with the connection. We cannot hear you well.
Oh, I apologize. Perhaps I'll just stop then and switch to different Wi-Fi. Bear with me.
Ziad, could we do the second presentation first whilst we sort out Mark's internet connection? Would that be okay?
Yeah, I'm happy for this to be.
Mark, do you want to come down to my office if you're in the hospital?
Sure.
Okay, so let's switch to the second talk. Robert, Simon, are you ready?
Yes, we're ready for you. We'll just share our screen.
So this second talk, thank you. From Palliative Care by Robert Broderick and Simon Atkin, to treat again or not to treat, managing uncertainty.
So, good afternoon, everybody. Can you hear us? Can you hear me?
Yes.
Yeah, marvellous. So my name is Robert Broderick. I'm a registrar in palliative medicine, and I'm here with Simon Etkind, who's a registrar and clinical lecturer. And we're here to talk about uncertainty. So our title is To Treat Again or Not to Treat. So I don't know if you're familiar with Slido, but it's quite a nice way of polling different attitudes and perspectives. So would you be willing to get out your phone and using a QR code or go to the website, type in that number, and we'll do a little poll. What I'd really like is if you could just say 1 or 2 words about what sort of patients you refer to palliative medicine, and you can have up to sort of 3 responses. So we'll just have a couple of moments for that. So 3 responses, fantastic. 4. I feel like one of those bingo cheerleaders, you know, counting in the numbers. So just maybe another 5 seconds. Great, so what have we got? So most people are saying, lovely, so pain, life, end of life, got some holistic care, got some cancer, frailty, symptom control, dying, end of life care, rapidly deteriorating, limited reversibility, expert symptom control, symptoms, breathlessness, end of life. Great, thank you. That's a really useful sort of representation of what our caseload looks like. So the case I would like to talk about doesn't really fit into that schematic. And it is not from 1990s palliative medicine, which is sort of this sort of mentality. If in doubt, give them some morphine, it'll get better. The case I would like to talk about is about uncertainty, as in keeping with the title of our talk. So we got this referral in September saying, approaching ceiling of care and potential to not improve during this admission. And it was a story of a 70-year-old man who had lost his swallow. He had severe progressive idiopathic oropharyngeal dysphagia, and it'd been getting gradually worse since 2016. And despite the speech and language therapists doing their best to advise him about thickened fluids, he just carried on eating what he wanted to. And as a result, somewhat unsurprisingly, he was readmitted to hospital on more than several occasions with recurrent aspiration pneumonia. And he received some antibiotics and got better and then went back home. He didn't just have that as an issue, however. So he had rheumatoid-associated usual interstitial pneumonia, and he had pulmonary sarcoid, thought to be quiescent, diagnosed in 1992. Peripheral neuropathy with foot drop, not clear whether related to sarcoid or not. He was profoundly deaf, pulmonary TB, type 2 diabetes. He was hypertensive, some chronic kidney disease, and he had heart failure. So more than one thing to contend with. So on this admission, he was admitted in sort of tail end of September. And during that admission, he had recurrent episodes of aspiration. And in total, over 3 months, he had 6 courses of tazocin. And each time he got better with pretty much regaining function, thinking about discharge. And then before things came to a head, he got another aspiration. And over the course of this admission, he gently got frailer, gently lost his reserve, which wasn't a great amount considering he previously lived in a ward and control flat with a package of care. And he was very clear that he just wanted to leave hospital. He wanted to go home, have all this behind him and get on with his life. However, it's quite difficult to discharge someone who's on IV antibiotics, and particularly difficult knowing that he's got capacity, but just was so overwhelmed with the choices available to him, i.e. stay in hospital for long-term antibiotics, go home with IV antibiotics, go home without antibiotics, have a peg put in, etc., go home to a nursing home, all just felt far too much for him. So he just resolutely was not able to express his preferences with regards to his future and indeed his medical care. And that left several medical teams in the quandary. So what's the limit? What are we able to offer this man? What's going to be for his best, bearing in mind he's got capacity? And one of our palliative medicine consultants, Dr. Ben Clark, visited this man on multiple occasions over his admission to very skillfully, in a very nuanced way, delineate where his preferences, both stated and unstated, lay. In order to put together a plan that really met his needs and also the needs of the hospital and the wider healthcare system. The family were very much involved. The respect went through several iterations and eventually everyone agreed that a peg should be inserted for peg antibiotics and or feeding. And just before Christmas, he was discharged to a nursing home, halfway through a course of IV antibiotics, but had some more antibiotics for a peg to go home with. And he had a lovely time in his nursing home. He knew he was going to come back with another aspiration pneumonia, but he was singing karaoke and really having a good time. And we knew he'd come back, as he, and needless to say, 3 weeks later, he's been readmitted, and he's currently an inpatient receiving IV antibiotics for an aspiration pneumonia. And of course, he's been re-referred back to palliative care. So is this a normal sort of case, or is this an abnormal sort of case? Well, in the 1990s, back to our sort of fictional time machine, we would be seeing mostly patients with cancer, if in a hospital they had a palliative care service at all, but mostly patients with cancer with single organ disease or single disease process, usually with a short prognosis, weeks or months, with a discrete symptom or two, pain, nausea, that sort of thing. A lot of focus would be on stopping treatments, and a lot of focus would be on delineating where patients' preferences were at. Whereas this case, a bit different. So we've got a non-malignant condition, lots of disease processes interacting, with a very uncertain prognosis, although we do know it's likely to be terminal. And that though the man was a bit breathless, he had some cough, he was a bit frail, there wasn't really a focal symptom that was the issue. It was actually the ambiguity and complexity of the situation that was the issue. And that was the main focus of all the intervention. And instead of stopping treatments, we were continuing treatments. And instead of the patient's preferences being clear, they were very unclear. So at that point, I'm going to hand over to Simon to explore what is typical these days in palliative care.
Thank you, Rob. That's brilliant. So Rob's given us a good summary of a complex case in palliative care, but I wanted to talk about 3 things that come up from this case. So firstly, what is typical for palliative care need in our current and future populations? Is it the 1990 situation, or have we moved on from there? Secondly, I wanted to talk about an issue that comes up a lot in this case, which is the issue of uncertainty. I want to talk about the experience of uncertainty and some ongoing research in that field. And thirdly, one of the issues in this case was the inability of the patient to express clear preferences. And I want to talk a little bit about care preferences in palliative care and what we might be able to do. So first of all, what is typical for palliative care? Well, and what's going to happen with palliative care need? The short answer to that question is palliative care need is going to go up. Now, this graph is some work we did projecting palliative care need on a population level in England and Wales. We used ONS mortality data and population projections. So this is an estimate of palliative care need based on cause of death. We made the rather broad assumption that everybody who died from certain conditions, such as cancer, heart failure, would have needs amenable to a palliative care approach in their last year of life. Now, that's not to say everybody with those conditions would need specialist palliative care referral, but they would have needs relevant to palliative care. Based on that, we projected palliative care need forward to 2040. Now, the orange line on this graph shows all deaths in England and Wales, both actual deaths up to 2014 and then projected based on population projections. The blue dotted line is our first projection, which just assumed that the proportion of people who die needing palliative care would remain the same. So in 2014, that was where our data ended, it was 75%. So if 75% continued up to 2040, that would be another 90,000 people needing palliative care. And that takes into account population growth and aging as the increasing number of deaths. But actually, if you look at the green and yellow dotted lines, these projections take into account what's been happening recently. So recent trends in deaths from certain conditions. And if we incorporate those trends into our projections, actually we can see that palliative care needs going to grow out of proportion, or is projected to grow out of proportion to demographic changes. So it's not just that our population is getting older. It's not just that it's growing, it's actually more complex illness. So palliative care needs going up in England and Wales by a lot. The same is true globally. This is just a map to illustrate that. The darker green is low-income countries, which in this study are set to see a huge increase in palliative care need by 2060. Obviously, there's greater uncertainty in this estimate because death mortality statistics are less reliable in some countries. What's going to drive this increase in palliative care need? We are expecting palliative care need to grow with age. So if you look at this graph, which is again from the England and Wales data, palliative care need in the age groups under 75 is either flat or reducing. And it's only in the 75 and up that we're seeing the big increases in palliative care need. So we're expecting our population to get older. That's perhaps what we would expect. When we look at what conditions might be driving this increase in need, again, this is all based on recent trends, so things can change. But if you look at the recent trends, deaths from cancer actually are projected to increase, and there's expected to be a dramatic increase in deaths from dementia. From this data, there's a trend to reduced deaths from organ failure, but there's a bit of nuance in that data because we know within that liver failure deaths are increasing, and deaths from, for example, cardiac causes are the least accurately recorded in the certification data. So there's probably more uncertainty around that. But cancer and dementia seem to be the big drivers of need. What about multimorbidity? Our patient was certainly multimorbid. And in this more recent study in Scotland, similar methodology, but in this study we had access to all causes of mortality rather than just underlying cause of death. And that meant we were able to examine deaths from multiple illnesses and look at the proportion of people dying with multimorbidity. Now, this isn't just multimorbidity as in the presence of any two medical conditions. This is the presence of any two life-limiting illnesses, so heart failure and cancer, COPD and renal failure, and so on. And even in 2017, that was 37% of deaths, but it's expected to almost double to nearly 60% of deaths by 2040. So multimorbidity, lots of serious illnesses, is going to be the norm. What does that mean for illness trajectories? Well, when we were thinking about palliative care and a cancer trajectory, this data looks at functional trajectories at the end of life, and the dark blue line shows the cancer trajectory, which is reasonably good function and then a rapid decline at the end of life, which is usually fairly predictable. So there's a time when perhaps palliative care input might be useful. The organ failure trajectory in the red is less predictable with these exacerbations, for example, an exacerbation of COPD or heart failure, and recoveries. And then there's the frailty or dementia trajectory, where there's a prolonged, unpredictable course of low function. But actually what we're saying is that most people are going to have multiple trajectories and have a very unpredictable trajectory at the end of life. And it'll be difficult to know what's going to happen next. What does that mean for models of care? Well, I've crossed out current in this graph because this isn't really the current model of care. This was perhaps the 1990s model in the top right, where curative interventions would continue, then they would stop, and you'd have some palliative care, and it was either or. Much closer to perhaps the current model is the bottom diagram, where palliative care is alongside curative interventions, and our level of input is fluctuating over time and perhaps episodic. So it's a more complex model of care to fit more complex illness. Now, how do all of these projections fit with what we see in this trust? So last week, in a quiet moment of the MDT, I had a brief look at our palliative care caseload of 90 patients. And I looked at a few items and found the following, that about half of our patients have cancer as their main diagnosis. It's a fairly old population, although you can see there's a big range. And there are actually two peaks in the 60s and 70s, which I think is the cancer patients, and then the 80s and 90s, which is perhaps more of the frail, older, multimorbid patients. We're only seeing 25% of our patients in the last days of life, so the majority aren't imminently dying. Lots of them are for symptom control, but there is a large minority that we're seeing for last year of life planning, seeing earlier in the illness course. And 10%, according to the RESPECT forms, were receiving curative or active treatment alongside palliative care. So based on that, what is typical for 2020's hospital palliative care? Is it the one on the left, the 1990s model, or is it more to do with what we saw in this case? Well, I'd argue that actually it's both. We're seeing cancer and non-malignant disease, often both together. We're seeing single and multiple disease processes, sometimes with a short prognosis, but often with an uncertain prognosis. And again, all of these things are perhaps true for palliative care now. And for me, I would say the common thread of what we are seeing is complexity. So that brings me on to the second bit. We see complexity and we see people with unpredictable disease courses and ambiguity as to where they are in their disease trajectory. And these are all building blocks of uncertainty. Uncertainty is perhaps the underlying construct. Some while ago, William Osler would have agreed. He said medicine is a science of uncertainty and an art of probability. And given that, it's surprising how little we actually know about uncertainty itself. So I've recently been working on a systematic review, trying to fill that gap and explore the experience of uncertainty in multimorbidity from multiple perspectives, trying to look at the uncertainty of patients, of carers and health professionals, and see what different players in this game are uncertain about. I've been looking at 44 articles of qualitative studies, which from this diagram you can see look at all the different perspectives. And they're from worldwide, 13 countries around the world, although looking more closely, these are Western countries and perhaps there's an absence in the evidence base of a broader cultural exploration of uncertainty. And looking at the findings, well, unpredictability is certainly there. In this quote, both patients and their carers were talking about the difficulties of not knowing what was going to happen. They knew that they had a terminal illness, but not when they were going to die and what would happen next. Complexity also evident, and there was a sense that each new condition was an extra layer of complexity, almost an exponential growth of complexity as the number of conditions increased. And things were often ambiguous. There tended to be a lack of information and unclear even what was not known or what was not communicated. So all those building blocks of uncertainty were evident. Looking more closely at the patient perspective, so there was uncertainty about the physical illness itself. This participant had pain and just didn't know what it meant and was uncertain about that. Another participant didn't know how or when to access care, what was normal for them. They didn't know. And for some, uncertainty was almost overwhelming and people felt powerless, stuck in this cycle of illness and losing almost their sense of self. And for me, that strikes true with what we heard about in the case, this cycle of illness and recovery. And I think that's certainly something that was the case there. Looking at health professionals, what were they uncertain about? Well, harms and benefits, very difficult to know what the benefits are of treatments and to judge harms versus benefits. If there are 30 things wrong, then which issue to prioritize? And often these patients are specifically excluded from trials, so we just don't have an evidence base. Professionals were sometimes uncertain of their role. Who was leading care when several different teams were involved? And there were communication difficulties and fragmentation of care in this quote causing pure chaos. So putting that all together, I've been working on this model of total uncertainty. You may have come across Cicely Saunders, the founder of the modern palliative care movement, who developed a model of total pain, saying pain was more than a physical thing, could be psychological, social, spiritual. I think uncertainty is similar in that it has multiple domains. There's this appraising and managing of multiple illnesses, psychological and existential impact, fragmented care and communication in multimorbidity, and also uncertainty of others, patients noticing when health professionals are uncertain and vice versa, contributing. All surrounded by a constant and unpredictable change because these illnesses do not stay still. So in our case, uncertainty was certainly paralyzing, overwhelming, inhibiting ability to express preferences and make decisions. And it affected health professionals too. Is there a solution? I suspect there isn't. Communication is certainly key, but what else can we do? So the last thing I wanted to mention, and I'll do it briefly because we're fairly short on time, is just thinking a little bit more about care preferences. So I would argue that as things become more complex and uncertain, the importance of a person-centered approach increases. And a key part of that is to deliver care in line with patient preferences. It's obviously difficult when people find it hard to express preferences. And preferences themselves are not straightforward or stable constructs. I spent my PhD looking into this, and it took a lot of exploration, even to understand what a preference is when it comes down to it. As part of my PhD, I did this qualitative study of frail older people after an acute illness, and their preferences were affected by the illness and care context, their experiences of care and their health changing, the way that they adapted to their changing health. So this participant said, well, I'm in a different position, so the priorities have changed. A key construct, and something that I use in my practice, is to think about preference in terms of normality. A lot of people, their preferences are underpinned by a desire to achieve some kind of normality, either getting back to an old normal or finding a new normal. This participant just wanted to get back to her old normal. The social context and the people around me were vital in the frail older population. And this little complex of arrows just illustrates again that we're not dealing with a static illness. We're dealing with a changing, constantly changed situation, and people can get caught up in that change. And this participant, who reminds me strongly of this case, said, when I come out of hospital, I always say that that's the last time. And then something happens and I can't fulfill that because, well, I'm back in hospital now. And that was that. Just the final thing to say really is that preferences are not stable. And in this blue box, there are a number of things that can either support stability of preferences or support instability of preferences. If people have family support and their preferences overlap with deep values, then potentially their preferences for care will be fairly stable. But if people are experiencing life events, changing awareness of their health, then preferences may change. So it takes a deep knowledge of an individual to really understand what might affect their preferences. And that's why perhaps this case needed such a great deal of input from our team. So I'm going to finish now, and I just wanted to, as take-home messages, to say that part of the core business of palliative care is managing complexity and uncertainty. I think that's clear from the complexity of our populations, who we are seeing and what's happening to them. It's not a sequential system. We work alongside other specialties, and it's really too early to refer. We even get involved on an episodic basis and then discharge and can step in again. I would say this because I'm researching it, but I think uncertainty is of key importance, and I hope I've persuaded you of that. Both our uncertainty as professionals and patient uncertainty should be addressed with careful communication. And the next thing I want to look into is how we can best do that, how we can best address uncertainty. Finally, it's important to elicit and explore patient preferences and reassess them when circumstances change. So I'll finish there. There's a few references on this slide, and be very happy to take some questions.
Yeah, thank you very much, Simon and Rob, for this really insightful presentation. I mean, you know, uncertainty is everywhere in care, but I mean, from diagnosis to treatment, etc. But I really find it, and I think everyone finds that this is the area of patient care where uncertainty is the most, you know, important here. And then I think, you know, what you, I'm not sure that certainty can be achieved anyway or desirable, but what you have highlighted is that on the patients, from the patient perspective, it seemed to me from your presentation that lack of information was a major factor in this uncertainty. So how can we do in order to improve this, in your opinion?
Thank you. Yeah, I agree. Lack of information was a key problem. I would say it was a problem for professionals too, because of the interprofessional communication, particularly at transitions of care from hospital to home or elsewhere. I think there's no easy answer. I think it's just that perhaps we underestimate how much time we need to set aside to communicate and the importance of it. I would argue that, you know, half an hour spent going through a complex history with a patient, ensuring the right people are in the room, that the people that they need to be are there, will save much more time in the long run, in terms of treatment that perhaps isn't something that was in line with their preferences. So I think it's just finding somehow the time up front to discuss preferences, develop those that relational continuity, and take as much as we can to communicate within an already stressed system.
And you mentioned that I mean, care preferences and patient preferences may change over time and over the course of the illness. Do we know anything about what are the factors that are that make patients change their preferences over the course?
Yeah, so I think it depends on the preference partly. Some preferences, for example, broad preferences to get home, to remain independent, are much more static than specific preferences about a treatment. So if somebody expresses a specific preference about a particular treatment, that's much more liable to change than a broad preference about their overall care. But even those broad preferences can change, and it tends to be the biggest factor, I would argue, that changes preferences, or that supports changing preferences, is a change in awareness. So perhaps after you've spent all that time communicating and sharing information and discussing with a patient, that would be a good time to reassess their preferences, because that information and that changing in awareness context might precipitate a change in preferences. There are lots of other things, but for me, I think that's the main one.
Okay, thank you very much. So maybe one question I was thinking about is do you think that maybe is there enough, in your opinion, randomized trials for palliative care, you know, in order to obtain quite, let's say, objective information about what works and what doesn't work for the patient? So do you think that this is an area in development, or should be developed in order to try to lessen this uncertainty about what we do?
Absolutely. Palliative care's evidence base is very limited. And in terms of research funding, we get, I think, 0.1% of UK medical research goes to palliative care. If you look at academic trainees, there are a quarter the number as based on specialty size compared to oncology. So we are very much an under-researched specialty. I think we do need more trials. I suppose I would argue that we need trials, but we also need multiple methods of research. There are as you mentioned, some uncertainties that we're not going to be able to resolve. And I think that where we see an uncertainty about treatment that we can resolve, potentially, then we should do a trial. But if we're in a situation where there is irreducible uncertainty, and I think there are some things that will always be uncertain with regards to care, then it's more about understanding the best ways to communicate that with patients and their families. So I think it's both of those things are needed.
Okay, thank you. I cannot see any question in the chat. I'm not sure that I have the right. If you don't see any questions in the chat, do you see any questions in the chat? No. Okay. Thank you very much, Rob and Simon. And
thank you.
We will move to the next presentation, which was initially the first one. I hope that the internet connection now is working well. Mark?
Yeah, it's all sorted. Sorry about that one, everybody.
Great. So I'll let you start from the beginning.
Sure. So thanks a lot. I'm Mark McClure, Renal Registrar. So this was a case that was jointly managed by Renal, Haematology and Respiratory teams just before Christmas. And I'll just jump straight in for the interest of time. So this was a 31-year-old man. He was fit and well with no past medical history. He worked for Argos delivering home appliances. Occasional smoker, occasional alcohol, but nothing to excess. His dad was a type 1 diabetic, but there were no other medical conditions running in the family. So symptom onset was 14th of November, and this was with diarrhea. But the diarrhea was pretty mild. He said he had slightly loose stool over a couple of days, which settled, and then 1 week later had a night of very loose diarrhea that he took some loperamide and settled with some loperamide. But there was no blood. It was non-bloody diarrhea. It was associated with intermittent crampy abdominal discomfort and some constitutional upset with malaise and fatigue. No other symptoms, but feeling unwell enough to present to Ipswich Hospital on the 9th of December. There were no night sweats, no weight loss. He didn't report having any dodgy meals, and there was no history of travel. So blood tests on admission to Ipswich, shown here. You see a raised creatinine with creatinine of 241 and a very high corrected calcium at 3.2. But the other blood tests were normal. He had a CT chest abdo-pelvis done at Ipswich, which reported as showing bilateral pulmonary infiltrates, splenomegaly and pancreatitis, and we'll review these in detail shortly. There was blood and protein in his urine, and he had a good urine output. So he was treated with IV fluids, he had some blood cultures, some empirical antibiotics, and got some IV bisphosphonate. But despite aggressive filling with IV fluids, so the following day, you can see his renal function has deteriorated. His creatinine rose up to 330. He'd become anemic with HB of 104, and there was now a marked thrombocytopenia with platelets dropping acutely from 352 down to 30. So when faced with an unexplained thrombocytopenia in this setting of possible sepsis, the key differentials to consider are shown here. So ITP and heparin-induced thrombocytopenia should be considered, but they're probably unlikely in this scenario given the acuity of the drop, and they would also be typically associated with a normal hemoglobin. So therefore a TTP or an HUS-like picture or a DIC is possible. Both of these conditions are associated with red cell fragments on blood film or schistocytes, and they can usually be differentiated from each other by the abnormal clotting and reduced fibrinogen seen in DIC. So the blood film from Ipswich did indeed show fragmented red cells, suggesting that there was microvascular hemolysis going on. And given the normal clotting and normal fibrinogen, this meant that a thrombocytopenic purpura or a hemolytic uremic syndrome was now top of the differential. So this case was discussed with hematology at Addenbrooke's, and as it was clear that it was going to require a kind of specialist MDT approach, and there was potentially going to need therapies such as plasma exchange, which could only be delivered at Addenbrooke's and not Ipswich. An urgent transfer the same day was arranged, which was a Friday. And the Adam TS13, which I'll talk about shortly, was urgently sent for processing at Addenbrooke's. So on arrival to CUH, he actually looked pretty well. His obs were okay. You can see there's low-grade fever, the SATs were a touch low, but he was not tachypneic, and there were some crackles on his chest and some mild abdominal tenderness. This was the admission chest x-ray showing bilateral opacification. We'll just review this in a bit more detail shortly. So the blood tests at Addenbrooke's were pretty similar to those at Ipswich, although the platelets and hemoglobin had fallen a little further. We very quickly knew that the Adam TS13 was normal, and therefore this excluded TTP. The LDH and haptoglobin were consistent with hemolysis. The PTH was suppressed, and the amylase was a little elevated. So given the, apologies, there's now a drill going on next to me. I'll persevere. Given the hypercalcemia and the suppressed PTH, a malignant process, including a lymphoma, was now top of the differential, although an autoimmune pathology like a pulmonary renal syndrome or an infective process was also being considered. So here I'll pass over to Dr. Carrier, who will review the radiology.
Okay, thank you, Mark. Okay, can we have the next slide, please? So we've seen his presentation chest radiograph where there's quite profound diffuse parenchymal infiltration. I think from a radiology perspective, this is best described as a reticular nodular opacity with lots of fine, poorly defined nodules throughout the lungs. One of the important kind of issues here is to not stop looking. And the red, green and blue arrows indicate lymphadenopathy in the right paratracheal and right hilar and AP window stations. So I've got on the right of the screen a normal chest X-ray where you can see that the demarcation of lung parenchyma up against the lateral border of trachea is very crisp. And here, indicated by the red arrow, we have the additional soft tissue. The green arrow shows both an increase in size, but an increase in density of the right hilum. And then we've lost the normal AP window, which is really evidenced by the aortic knuckle definition being completely obliterated. So the pattern of lymphadenopathy is often described as the galaxy sign of sarcoidosis. However, with such profound parenchymal infiltrates, not entirely typical of sarcoid on plain radiograph, the patient then proceeded to a CT, which is on the next slide, please. So when faced with such diffuse lung disease, it's important to try and establish where in the lung parenchyma the abnormality is located. And with nodules, the most important question is, are these nodules perilymphatic or are they random? The differential diagnoses, depending on this, are widely different. Random nodules will be sprayed throughout the lung parenchyma. So in the image on your extreme right, you can see that the nodules seem to be clustered in the mid and upper zones with relatively sparing of the lung bases. So that goes against them being random. And the image on your left shows the three blue arrows, shows that the nodules seem to be clustered around the perilymphatic region or fissural region, which is a good sign that these nodules are perilymphatic in distribution. The fact that the parenchymal changes are most marked in the upper and mid zones are most in keeping with sarcoidosis. With the next slide, please. So this is the same CT. So we didn't administer intravenous contrast due to the renal dysfunction. However, we wanted to look for ancillary signs of sarcoidosis. The middle image shows lymphadenopathy in the subcarenal region. Normal lymph nodes can measure up to around 1 centimeter, and this was over 2.4 centimeters, so significantly enlarged. The image on your left shows the myocardial contour defined compared to the blood pool, suggesting a significant anemia, so an infrequent observation on CT. And then the coronal image on the right of the screen shows unobstructed kidneys, and there was marked splenomegaly. And the kidneys, to me, look slightly enlarged, measuring about 13.5 centimeters, but again, no obstructive features. So can we have the next slide, please? So the radiological differential diagnoses purely on the CT and plain film. Sarcoidosis is by far the most likely diagnosis for the thoracic appearances. The pattern of perilymphatic nodularity, the lymphadenopathy, together coupled with it's the most common disease we see with this type of imaging. Much more rarer entities for the remainder of the differential diagnosis. So GLILD is a disease almost invariably associated with common variable immune deficiency. So not apparent in this case, as was the lack of occupational history, which may suggest something like silicosis. Lymphangitic spread of tumor is a diagnosis we would not like to overlook. However, the nodules would be very much more random, and more importantly, the patient would not be with relatively mild symptoms with such diffuse lymphangitic spread of tumor, and we'd expect to see a primary cancer and have associated signs such as pleural disease and metastatic disease, which weren't apparent. So on imaging grounds, sarcoidosis was felt to be the most likely diagnosis. I'm just going to hand over now to Dr. Walker to take you through some of the hematology findings.
I'm not sure if Dr. Walker's able to join, but just in the interest of time, I'll just have a look at these films for him. So the peripheral blood film is confirming these schistocytes. fragmented red cells, and showing hardly any platelets at all, confirming the thrombocytopenia. And this was the bone marrow aspirate, which was reported as being normal trilineared cells without any atypical cells. So essentially, was a normal bone marrow. Here's a snapshot from the immunology tab in EPIC. So this is showing a negative autoimmune screen, normal complements, no monoclonal band or paraprotein, normal IgG4, but what is abnormal is the elevated serum ACE at 84. Blood cultures were negative, viral screen was negative. And then on the 13th of December, this is now the Monday, the bloods hadn't really changed, although the creatinine had fallen a little bit. So this is a summary of the key features so far. We've got a 31-year-old chap with a microangiopathic hemolytic anemia and thrombocytopenia, an acute kidney injury with blood and protein in his urine, high calcium, high serum ACE, splenomegaly, pancreatitis, extensive pulmonary infiltrates, an inflammatory response, and now we realize he had a normal bone marrow. So we still thought we were dealing with an infiltrative process, and lymphoma was top of this list still. Sarcoid, IgG4 disease, Castleman's were being considered, possibly driving a secondary TMA. So in search of the tissue diagnosis, a kidney biopsy was performed under platelet cover. And I'll now pass over to Dr. Thiru Navukarasu to review the renal biopsy images.
Thank you for that, Mark. Can we have the first slide? So each kidney, on your left is the normal kidney. Each kidney is composed of 1 million nephrons, and each nephron is composed of a glomerulus, which is a bunch of capillaries surrounded by tubules which are packed together. And you see the normal, and you see the case here, which is the same magnification, showing you it's quite different from the normal. At arrows B and C show tubules which should have been very compact, but they are now showing dilated lumina lined by damaged epithelium. This is acute tubular injury. And the glomeruli, two glomeruli, they look abnormal, but we'll go to the next slide, which would be better to show you higher magnification. Now, to your left is the normal, where it's a bunch of capillaries, as I told you, and H indicates one such capillary. Each capillary is lined by endothelial cells, which are very attenuated cytoplasm, so that the lumina are quite widely patent. And these capillaries are all given structure like the branches of a tree. The leaves, capillaries are the leaves, and the branches of the trees are indicated by B, which we call the mesangial region. And this is the one, the supporting structure. And on the C, you can see the normal tubule. Now here on the right side is the case. And you can see right away, first, you cannot see any supporting structure. The mesangium has disappeared. We call that mesangiolysis. And then arrow D shows you the capillary lumen, one such capillary lumen, where you can't see the lumen because it's lined by dilated, damaged endothelium. And arrow E shows, because there is endothelial injury, there are secondary effects of inflammatory cells coming in, and that's what arrow E is showing you. And because of this kind of narrowing of the lumen, you get aggregation of red cells, and therefore injury to red cells and hemolysis, which of course I can't show you on this slide, and eventually you can get even thrombi. So this picture we call thrombotic microangiopathy. This is evidence of injury, microvascular lesion secondary to endothelial cell injury. This is a histopathological diagnosis. This doesn't tell us the cause of the injury, and that needs clinical pathological correlation. And I will now pass it on to Mark.
Thanks very much. So to make a diagnosis of thrombotic microangiopathy, you need two things. The first you need is the tissue biopsy, which we now had, demonstrating platelet and fibrin-rich thrombi in the microcirculation. And as Dr. Thiru just said this causes microvascular occlusion and then an ischemic organ dysfunction. And then the second thing you get is the hematologic blood picture that we are seeing of thrombocytopenia and intravascular hemolysis declaring itself as the red cell fragmentation. But as Dr. Thew says, it's not a diagnosis, it's a description of a pathological process, which can be driven by a number of different diseases. So the first thing, the most important thing to exclude acutely is thrombotic thrombocytopenic purpura, or TTP. So this is caused by deficiency of ADAMTS13, which is a proteinase needed to process von Willebrand's factor properly. And without it, there's uncontrolled platelet aggregation at the endothelial surface. So this is a hematological emergency with a very high mortality rate if untreated. So if the ADAMTS13 is deficient, which we say less than 10%, they need urgent plasma exchange and then usually followed up with some rituximab, which is usually very effective. The second thing to consider is sugar toxin associated hemolytic uremic syndrome. So this is caused by sugar toxins, which are produced by specific serotypes of Shigella and then actually more commonly E. coli strains, which are present in contaminated foods. These typically cause outbreaks that are very well usually publicized in the media. And the toxin binds directly to the endothelial cell and it can induce apoptosis and inflammatory response. So there's typically a diarrheal illness that lasts 3 to 14 days, and the diarrhea is usually profuse and bloody. 10 to 20% of patients develop the clinical syndrome of hemolytic uremic syndrome with a MAHA, thrombocytopenia, and acute kidney injury. It's diagnosed with a stool sample looking for the toxin, and unlike TTP, the treatment is purely supportive. And it mainly affects kids, but it does occur in adults too. There are then lots of other secondary causes, including drugs, cancer, some autoimmune, malignant hypertension, preeclampsia, and some infections, all of which need to be considered and looked for. And then really important process to consider is atypical HUS, which is now referred to as complement mediated HUS. So just to recap, and I'll just focus on the alternative complement pathway. So unlike the classical and the lectin pathways, which require a stimulus to be activated, antibody binding to antigen and then C1q for the classical pathway, these recognition of mannose residues on certain bacteria activates this pathway. But unlike these two, the alternative pathway is actually always turned on. So C3 is the substrate, and that's always continually being hydrolyzed at low level into C3a and C3b, and then the C3b joins up with factor B here, and then when it joins up with another factor C3b, this is what forms what's called a C5 convertase, which can cleave C5 into C5a, which is a powerful anaphylatoxin and recruits various immune cells into the site of injury, and then lays down C5b onto the cell surface, which joins up with other complement proteins to form this membrane attack process complex. And this MAC, the membrane attack complex, can punch holes in cells, causing lysis and cell damage. But importantly, at this stage here, the C3BBB is itself a C3 convertase, and that can cleave more C3, which can cause an amplification loop. So it's always turned on and it can self-amplify. So therefore, if it's not tightly regulated, you're in trouble. But it is regulated by several complement regulatory proteins, which basically limit each one of these steps, and the amplification step especially. And it is deficiency of these regulatory proteins that is what causes atypical HUS, which is characterized by this uncontrolled activation of the alternative pathway, and that's what leads to the endothelial injury. So the deficiency of complement regulatory proteins is usually due to loss of function mutations in the genes that encode these factors. Factor H is the most common, followed by MCP and factor I. And there may also be autoantibodies against these factors. And then conversely, they can have gain of function mutations, which amplify the alternative pathway. And that's also recognized as a cause of disease. This is a very rare condition, 0.4 per million population. The treatment used to be just plasma exchange, as this will remove the antibodies and then replace, if there are autoantibodies, then replace the abnormal complement regulatory factors if exchanged with FFP. But the outcomes were dreadful, just in terms of death and end-stage renal failure. And you can see that the outcomes depended on what gene mutation, specific gene mutation the patient had. However, the treatment of atypical HUS has been completely transformed by eculizumab. This is a monoclonal antibody against the C5 bit of the complement pathway, and therefore eliminates the ability of complement to form that membrane attack complex. So this was the seminal paper published in New England Journal in 2013 that led to the marketing authorization of eculizumab around the world. They looked at two cohorts. One of the first cohort were patients known to have HUS that had been treated repeatedly with plasma exchange, and then the second cohort was a newly presenting cohort of patients with atypical HUS. Both cohorts showed normalization of platelets and a rapid improvement in kidney function, which persisted throughout the whole year of treatment. So this really was a transformative intervention for patients with atypical hemolytic uremic syndrome. However, the cost is quite extraordinary. You can see here, this is the NHS list price, over £390,000 per year. And the duration for therapy may even be lifelong for certain gene mutations. So approval for its use for atypical HUS requires approval through NHS England and this National Renal Complement Therapeutic Centre, which is up in Newcastle. So this is what we thought we were dealing with at this time, a case of atypical HUS. And so we activated this urgent referral to the National Renal Complement Therapeutic Centre. And this is just the form, the long form that needs to be completed. And you have to basically detail all the important negatives and send urgent blood for genetic testing. At this point, the sugar toxin screen was still awaited. The chap, if you remember, his diarrhea was pretty mild and he didn't have any diarrhea with us, so we couldn't send a stool sample. But so a rectal swab was sent instead of the stool sample. Samples had been sent to Newcastle. We were awaiting authorization for eculizumab, plasma exchange. We're about to start plasma exchange. The whole time, the patient remained very well. But as things didn't quite add up, we, especially with regards to the calcium and the serum ACE and the chest X-ray findings, at this time, the respiratory team did a bronchoscopy. So then, before any plasma exchange and before any eculizumab was started, day by day, the creatinine started to fall and the platelet count started to rise, such that on the 20th of December, he had a serum creatinine of 130, hemoglobin of 86, and platelet count of 240. We then learned that the sugar toxin was negative, and we learned that there was no complement mutation had been identified. So at this point, I'll pass over to Dr. Martinelli to review the results of the EBUS FNA.
Thanks, Mark. Given the time, I'll take 20 seconds. So if we go next slide, all I'll mention is that we did an EBUS and we took samples of his lymph nodes. We couldn't see any hemorrhage in his lungs, and we did a lavage of his middle lobe. Next slide. Next slide again. And actually, we're very satisfied to see we found a non-necrotizing granuloma consistent with sarcoid. His AFB and micro is all negative, and his differential cell count from the lavage was difficult to interpret because we'd just done the biopsy, but was probably consistent with elevated lymphocytes, which again would work with sarcoid. So we started him on prednisolone, and he remains under our outpatient follow-up for that. Thanks. Back to you.
Thanks, Anthony. Very quick. We have two diseases, essentially. We have got the TMA that was preceded by a diarrheal illness and was self-limiting. There's no gene mutation of regulatory complement components. So we think that this is most in keeping with a sugar toxin associated HUS. And although the rectal swab was negative, this was done about 4 weeks after the diarrhea had settled. So it's probably likely to be unreliable. And then we have a pretty convincing diagnosis of sarcoidosis, which we are interpreting as a coincidental diagnosis, as there are no known associations and no known case reports linking the two conditions. And this chap was seen just last week in the respiratory clinic. He's keeping well. He's had a normal blood test. He's actually back at work, which is all great to hear. So the outcome has been great. And hence the name of, slightly obscure name of the talk. So this chap on the left is Occam. And we're taught in medicine to use the principle of Occam's razor, which is always to assume that there is a single cause for multiple symptoms, and then try and find the unifying diagnosis for everything. And that's what we were trying to do with this chap for the first 5 days, but then essentially we couldn't, because in fact there are two things going on. There's the TMA explaining the acute kidney injury in the hematologic blood picture, and then there's the sarcoid explaining the calcium and the chest findings. So we think in a world of increasing complexity, especially with patients with more than one comorbidity, Occam's razor is sometimes not the right thing to use. So hence the title of the talk, the blunt razor. Thank you very much.
Okay, thank you very much, Mark, and all the others for this really multidisciplinary presentation and very interesting case report. I was thinking, I wanted to ask you back when you showed the microangiopathy, whether the pulmonary infiltrates or microangiopathic, but it is remarkable to see this this unfortunate association. Was there any involvement in other organs related to sarcoidosis, in the eye or the heart, or?
There were not in the eye, not in the heart, as far as we know. Although I didn't see.
And it's remarkable that the kidney did not show any signs of sarcoidosis involved.
No, it was just TMA in the kidney, no signs of sarcoid. He had splenomegaly, which we are attributing to sarcoid. But
Pancreatitis could be related to it as well, but no, his vision was fine. He'll probably get that. He will get that checked at some point. But yeah, not otherwise nothing that would really fit. No erythema nodosum or anything like that.
Question from Ken Paul: did you have the results of 1,25-hydroxy vitamin D levels?
I don't think we checked the 125 vitamin D actually. That's something we can follow up with.
Okay, we will stop here. Thank you very much. Very interesting. Thanks. Bye.
Thank you.